Good morning and welcome to the Davies webinar being presented by Advocate Health on rationalizing blood product ordering through health information technology. This is a Davies Award-winning use case for the value of health IT, manager of quality and patient safety, and it's my pleasure to moderate the presentation. Core to the HIMSS mission is promoting the use of health IT to improve the quality of healthcare delivery. HIMSS promotes and advocates the integration of clinical decision support, best practice guidance, access to clinical data to analyze progress, and IT-enabled patient safety tools for all healthcare organizations, clinicians, patients, and community members as vehicles for improving patient outcomes. The HIMSS Nicholas E. Davies Award of Excellence is the pinnacle of the HIMSS Value Recognition Program. Davies Award recognizes outstanding achievements of organizations from around the world who have utilized health information technology to improve patient outcomes and value. The Davies Awards winning use cases have been peer-reviewed to validate sustainable, improved patient and business outcomes resulting from health IT-enabled care delivery. It's my pleasure to welcome our speakers for today's webinar. We have Anupam Goel, who's the VP of Clinical Information at Advocate Healthcare and Inpatient Chief Medical Information Officer, and Beth Help, the Manager of Clinical Effectiveness. And I will turn it over to you all, and you can begin.
Hi, Arnold. Good morning. Thank you. It's a great honor to be here this morning with Dr. Goel to talk about Advocate's experience with integrating information technology into improving our blood ordering practices. So thank you for that. Next slide, please. I'd like to share a little bit about what Advocate Healthcare is. We're located in northeastern Illinois in the greater Chicagoland area, and we've got over 3,000 inpatient beds spread over about 12 hospitals. Included in that are 250 outpatient sites of care, 6,000 physicians on staff, and over 10,000 employed nurses and advanced practice clinicians. So we've got kind of a large footprint, where health systems in Illinois are concerned. So I wanted to include that so you get a sense of like the scope of the communication plan and how this was spread. Next slide, please. Problem here. We're often asked, why did Advocate decide they wanted to take up this idea of transfusion use? And one of the things that our leadership noticed, especially our clinical leadership, is that year over year we had an increase in blood product use. So that was concerning, but not so much if you're seeing a concurrent need for that. One of the things we did not see is that our case mix index was changing. In other words, we weren't doing a whole lot more surgeries or a whole lot more trauma that would explain this overall use. So we kind of hit a pinnacle in 2011 where we hit a high point where about over 28,000 of our patients received transfusions, and we hit about 62 units per 1,000 adjusted patient days. That had been steadily climbing, but it really hit a peak in 2011 and kind of took a turn north. That meant that we were spending about $26.5 million in blood product use every year, and with no thought that was going to decrease anytime soon. When leadership started to look at this, they rapidly discovered that we really didn't have any method to track these practice patterns against the clinical evidence. So in other words, there was nothing that explained clinical decision-making and getting these transfusions into the patient. And so one of the key strategic goals was that we needed a culture shift in our physicians to weigh the risks of blood transfusion against the benefits. I think that for those of you who are acquainted with any of the literature at all in the diffusion of evidence into medical practice, sometimes it can take quite a long time, a number of years for that to happen. So our leadership was a little bit concerned that maybe practice hadn't caught up with the clinical evidence. So that's why they really believed that we needed to invest in this to make a change. Next slide. The other thing that drove this is that we had a very strong physician-focused culture without a lot of feedback on practice use. So, for example, you might have two surgeons on the same medical staff with neither one really having a good understanding of how the other used blood products. And so that was so one of the key goals of this was to try to change that. Next slide. Was actually to develop a data set to describe current state. So Advocate is lucky enough to have an enterprise data warehouse that houses and aggregates and links large amounts of clinical and ordering pattern information. So one of the first things we did was program that system to be able to show what the hemoglobin level before the time of a transfusion was. Then we leveraged the Midas Blood Bank module to look at transfusion counts and ordering providers and how they were using that blood. Next slide. Those data, we created graphical arrays that showed leadership where our transfusions were clustering. And if you look at the histogram on the top, you can see that you've got a big cluster around the 7 to 9 range, and then you've got these things out on the tail, especially all the way out to the right side of the graph, that showed that there were a significant number of physicians that were really transfusing when the hemoglobin was kind of high. So this actually is in contradiction to the best scientific evidence we had. And then the number of transfusions that were given outside of those hemoglobin ranges were displayed for our leadership. Next slide. So the next thing we needed to do was develop consensus among our clinical experts. So we recruited some clinical experts, most specifically a system chairman who's a trauma surgeon who understood transfusion medicine and was widely respected in our medical community. And then he was recruited to reach out to medical staff leadership and to ask their endorsement for this program. One of the things that we learned that we'll talk about a bit in the marketing campaign is that when you put credible physicians or credible clinical experts in front of the physician community, there really is a response from them. They respect evidence and they respect clinical expertise, and so that was a key part of engaging our clinicians. Then, because blood transfusion is a multidisciplinary process, our team also included nurses, blood transfusion service team members, and laboratory technicians. Next slide. Organizational structure we put in place. Prior to this initiative, we had not had a system structure that drove policy or created policy based on evidence for the Advocate system. So the System Transfusion Safety Committee is that group of clinical experts and process experts in blood transfusion that were recruited from across the system to make policy. That group chartered specialty task forces that tackled specific aspects of the clinical care of transfusion and how it was used. And then each Advocate site developed its local transfusion safety committee that actually enacted and oversaw policy implementation at the local level. Next slide. When you look at the transfusion process, is that it's a multi-step endeavor. So it starts with pre-transfusion testing. The physician looks at the results of that pre-transfusion testing and then thinks about that and says, what's the medical decision here? Does this patient need a transfusion or not? And then once that decision is made, the correct blood product has to get into the patient safely. So this is where nursing and laboratory and the blood bank come into play. And then safe administration at the bedside to guard against any kind of blood transfusion reaction. Next slide. On pre-transfusion testing and the medical decision to transfuse. So we went upstream. The committee decided to go upstream from this, and so we looked at part of pre-transfusion testing looked at preventing iatrogenic anemia. One of our mottos was, let's try to let the patient keep their own blood. So we actually re-engineered the size of the blood tubes we used across the system, so we were taking the least amount of blood out of the patient whenever there was whenever blood samples were taken. Especially on young children or patients that don't weigh very much. If you're in the hospital for a number of days and we draw blood 4 or 5 times a day and we use big tubes, just the phlebotomy alone can decrease your hemoglobin. So we actually had a full court press to try to change that. Then on the medical decision to transfuse, we developed evidence-based transfusion guidelines that actually showed the consensus on safe blood product use through the medical staff. These guidelines were then embedded into the EMR order sets and were supported by an educational campaign that explained these guidelines, why they were evidence-based, and what it meant to the patient to comply with these guidelines. Then the last step was to provide feedback and online public reporting of our blood transfusion use data. Next slide. Tom now, who's going to explain how the EMR order set process that was placed in an advocate supported the effort of safe transfusion practice. Anupam?
Thanks, Beth. So really, a lot of this groundwork was laid by the clinical team saying, how do we want to set this up? And so that's what you heard earlier from Beth. My piece is really to take some of that clinical leadership and translate that into the EMR. So what you'll see in the slide here is we used evidence and input from the clinicians to say, what do you want to show to help drive decision-making at the point of ordering? So I think the first thing that we were really instructed to think about was provide the evidence in a clear to easy read format, and then some suggestions around what amount of blood product might need to be transfused for this particular case. So that was the first requirement. The second was showing patient-specific information, including the last hemoglobin, so people can make a personalized decision for that patient based on the last hemoglobin. And then include all the elements to complete a transfusion. So a user doesn't have to go to a process to do the consent that's separate from the process to transfuse blood, to do a different process for the CBC to check after transfusion. In talking with the clinicians, they felt very strongly that we need to have different order sets, even if the content was 95% identical. To help the clinicians drive for specific clinical scenarios, we developed 3 different order sets. 1 for actively bleeding patients, so they're bleeding right now, let's do something quickly. 2, the not actively bleeding, we don't know what the bleeding source is, and it seems to be a slow loss. And then those patients who are going to surgery emergently or in the emergency room. So what we show you on the screenshot on the right is a list of these different order sets, or power plans in this case, that have the content that may look a little different, but it really drives the clinician at the point of ordering to make a decision based on what makes sense to them. The bleeding set, which you'll see is some instructions in purple, that's advocate's signature color, that says if you want to do more than 40 units, go to a different ordering process, and then all the pieces that are in place, the type and screen, the transfuse order, the consent, and then the post-transfusion. That's all listed. In our EMR, the little white X in the blue circle represents additional details, and the bottom half of the screenshot shows you how further along would you need to be to make that work occur. So the user would complete these fields, and upon clicking signature, this additional form shows up that says, you are placing orders on the following patient, and gives you the last set of details around blood products. And then beneath that, it lists some criteria for blood transfusion. So that evidence says, here's what we think would be appropriate to give that blood. If you choose another reason, we'd like you to explain that reason in the free text box. At the bottom, there's some more additional details around what we think the reasonable blood transfusions look like, and the pathophysiology around why we think we need additional blood for oxygen carrying capacity. In half there at the very bottom. Again, just informational, nothing to drive the user. Really, the key for us, we think, was the middle section that says, check the box that you think is most appropriate for this patient. Is it the hemoglobin of 7, hemoglobin of 8 with coronary artery disease or unstable angina, hemoglobin of 9 for induction therapy of acute leukemia? Not actively bleeding, and what you'll see is the content looks very similar. The idea here is that we are trying to acknowledge that the clinical leaders will see different things for these patients and may think a little differently, even if the data points are the same. So just want to highlight that we have orders, and then we have information to help drive the appropriate ordering process. Beth, I'm going over to you.
Hey, thanks. We're going to close out the presentation with a little bit of a description of our marketing campaign. One of the things that the system committee felt was really needed was sort of a full court press to try to spread the evidence about this, not just in a scientific manner, if that makes sense, in terms of like articles posted and lectures, but to actually create sort of a marketing heuristic or rule of thumb that would guide behavior. In the order sets Anupam showed you, what you'll see repeated over and over again is 7 grams, 7 grams, 7 grams, 7 grams of hemoglobin. The other big key takeaway from the scientific evidence, boiled down again to an easy-to-remember heuristic, is that don't give 2 units of blood if 1 will do. You're trying to get the patient's hemoglobin up to 7, So if they're not actively bleeding, and 1 unit will get you there, don't give 2. So our slogan was 7 is the new 10, 1 is the new 2, less is more. So the key message we wanted to get across is that the evidence showed that although we might have been thinking about blood, clinicians might have been thinking about blood as something that was sort of an unmitigated good for the patient. How can more hemoglobin be bad? In reality, whenever you do a blood transfusion, you're actually doing a human tissue transplant. And tissue transplants carry some downside. And so part of what we wanted to do was drive that message home with a marketing campaign. Next slide. Actually showed data publicly, both at the site level and both at the system level. And so what this slide showed is that as our clinicians adopted these principles and embedded them in patient care, they could see the data change. And one of the things that I think is interesting about human psychology is that, when you're trying to move a graph, if your behavior actually starts to move the graph, it's very motivating. And so people are empowered to pay attention and to really watch this. So these are 2 charts that get a lot of attention still every month and that people really look for. The other pleasant surprise we found was the amount of clinical dollars that were saved by not overusing blood products. As you can see, we went from about $26.5 million to now here at Advocate we average about $17.4 million annually on blood product use. So that is not an insignificant saving, especially in this healthcare market. Those are dollars that can be repurposed for other needs. And again, that $17.4 million is in the context of actually adding 2 more hospitals to Advocate between the time when the initiative started. Next slide. Then there's an abundant scientific literature. This goes to the point I made about avoiding complications from unneeded blood transfusion. Every year we publish for the Advocate clinicians the clinical benefits that occurred as a result of their work, from complications avoided, that you drive complications for blood transfusion down about 4% for every unit you avoid. Patient days reduced, nursing hours reduced. The nursing hours repurposed to adds up really rapidly. We did some time studies, and there's some literature on this that shows that nursing hours related to just hanging blood, taking the blood specimens, and monitoring the patient is about 2.2 hours of nursing time. So you give every nurse on your nursing staff potentially 2.2 more hours by decreasing unneeded blood transfusions. You're actually doing good things for patient care in your organization. And then again, from avoiding these transfusions, you get lives saved. So we create these graphics, and we break them out, and we publish them clinically and publicly for all of our sites to see. Next slide. Oh, okay. For the future, this is the Advocate Transfusion Safety Committee. They've developed into a group that is definitely not willing to just sit on past successes. We're constantly looking to improve our quality in blood transfusion use and to stay up with the clinical evidence. So newer products, future iterations that are coming down the pike are new verification products, fewer blood product options, and then creating a greater understanding of the antibody status to reduce the risk of transfusion reaction. One of the things that we were able to achieve because of the stewardship value of this initiative is we were able to transition the whole system to leukocyte-reduced blood, and we believe that was really a good thing for our patients. Next slide. New frozen plasma, blood plasma, platelets, and albumin. We have a massive blood transfusion protocol that's evidence-based that's currently undergoing its second review. There's some new evidence about the utility of fresh whole blood, so we're probably going to be changing that again. We have a group that really stays up with the clinical evidence. And then the maternal hemorrhage protocol has incorporated the use of new medications that really prevent blood loss in hemorrhaging mothers, such as tranexamic acid. So we've actually developed a culture that actively looks for new technology or new evidence and applies it into clinical practice as rapidly as possible. Next slide. for some closing comments, is that some key lessons learned is that the clinical evidence and trusted clinicians can really help change an organization's culture. This was definitely not operational leadership, but this that